Good afternoon, everyone. Thank you for joining us today for Aspire to Knock Out Pneumonia Readmissions webinar series, webinar number 6, Aspire Plus, the implementation model to drive results. We would like for these meetings to be very interactive, so we are anticipating that you will be highly engaged in today's session. We encourage you to ask questions, share information throughout the webinar today utilizing the question and chat panels. We will keep all lines muted to cut down on feedback, distractions, and echoing. Before we get started today, I'd like to go over the logistics for today's session. As stated before, all lines are currently muted and in listen-only mode. Please chat with your colleagues, hosts, and panelists through the webinar today utilizing the chat panel. You can find it by clicking on the chat bubble on at the bottom center left of your control panel. Please make sure your to setting is set to all panelists and attendees. This session is being recorded and will be made available on the NCHA website and through email notifications shortly after the conclusion of today's session. Presenting for you today is Dr. Amy Boutwell, founder of Collaborative Healthcare Strategies. At this time, I'd like to turn the presentation over to Amy.
Okay, thank you, Sarah. Welcome, everyone, and happy back to school season. Hard to believe it's September 6th already. So thank you for taking time out of these busy post-Labor Day days to join us for webinar 6, as Sarah said, in our webinar series. Just as a reminder, and for those of you who are joining us for the first time possibly, the purpose of the Knockout Pneumonia Readmission series is really to support your efforts to reduce pneumonia readmissions. You all know that North Carolina pneumonia readmission rates as well as pneumonia mortality are high, and that's really the call to action that brings us together. And so what we're doing is bringing field-tested, evidence-based strategies and tactics to you through the Aspire guide and applying it to the special case of pneumonia readmissions. Of course, we know that you're usually working on more than just pneumonia readmissions, and so we want you to have high-level strategies as well as specific coaching in terms of making your readmission reduction and your pneumonia readmission reduction efforts as successful as possible. So as we move through the content, we invite questions in chat, and we certainly want to continue to support you as we move through our September and October webinars leading up to our November in-person meeting. So for those of you that have been following along, we're covering the main components, or we've already covered the main 6 chapters of the Aspire guide. And you can see the webinars that we've had and the sections of the Aspire guide that those correlate to. And today, I'm really excited to bring to you content that you cannot get from the Aspire guide itself. It's content that emerged from detailed, intensive implementation of the Aspire method with community and teaching and safety net hospitals and rural hospitals just like you, and what we learned about the implementation model that drives results. So this is extra content today, and I'm really glad that we have the opportunity to spend the time to talk about what we've learned about the principles of implementation that really helps to get the results that you're seeking to achieve. I just want to orient you to, in October, I really feel like it will be time for you to raise your hand, let Trish and Sarah and the team know where are you in your knockout pneumonia readmission journey, what questions do you have as we prepare to make the most of our time together at our in-person workshop November 2nd. And so I'll emphasize this again at the end of the webinar today, but we really would like you to come to the October meeting ready to tell us about your aim, where you are in terms of your the interventions that you're deploying, how you feel the reliability of your implementation is, and what type of results you feel like you're seeing. Because the workshop in person, you consider this a consultative workshop. This is an opportunity for you to say, hey, we're making some decent progress, but we haven't had the breakthroughs we're looking for. How can we get some breakthrough results? And that's really what we want to use our time together in November to do. And then coming, as we wrap up our time together, we'll be creating 37 and 30-day action plans at the November 2nd workshop. And so December 6th will be perfect timing to hear from you. What were you able to accomplish, and what lessons did you learn, and what next steps do you have coming out of the 30 days that have passed since the in-person workshop? And so it will be an open round-robin office hours type of a webinar, but very informative, as you're all feeling like you're working as hard as you can, and you've thought of all the best ideas that you can think of. And coming in out of November and December, you'll hear what your colleagues are doing and what tests of change they have made. And that will most certainly inspire you and spark your thinking about what next steps you can take as you advance your readmission reduction work at your own hospital. So as a reminder, and really excited to remind you and encourage you to sign up and register for the November 2nd in-person meeting. We're targeting 8:30 to 3 o'clock time period. You can see it's going to be at the Novant Health Conference Center in Winston-Salem. And because this is an interactive workshop where you're going to develop action plans, you're going to be talking about your specific target populations and interventions and implementation strategies. We're limiting the participants to 75 total. And so we really encourage you that if you're ready for this type of detailed acceleration work, to please register so that you can secure your spot. The entire day will be about workshops, so it will be interactive. It will be we'll ask you to really use the time to advance your work, and the workshop structure will be a facilitation to help each of you think about the various elements of your readmission reduction, and specifically your pneumonia readmission reduction work, and we'll come out with some specific strategies to strengthen that work. So really moving away from didactics that we've been doing in the webinar series and moving into where do you stand now, and how can we help get you more success into the future. So as a reminder, the ASPIRE method is broadly applicable, and that's why it's so well suited for not only our focus here and our call to action about pneumonia readmissions, but it really it ties together your work on any other target populations, including pneumonia readmissions, because it's a methodology that can be worked through given the priority that you've decided on. And so if you've decided to focus on pneumonia patients being discharged to home, or if you've decided to focus on all pneumonia patients, regardless of discharge disposition or payer status, or if you say, well, we're focused on pneumonia, but we also have to keep our focus on CHF and heart failure, whatever your targeting strategy is, the ASPIRE method will help you then make the most of developing and delivering a whole person transitional care strategy for that target population. And the ASPIRE guide has been widely disseminated, and that's really where the experience, the implementation experience of today comes into play, as there have been many hundreds and over 1,000 hospitals now with stories to tell about implementing the ASPIRE method. The ASPIRE framework you'll recognize on the front of, this is the front page of the actual PDF document on the Agency for Healthcare Research and Quality website, and this is the link down there in the dark purple that you can see. So if you haven't read the ASPIRE guide, perhaps I could encourage you to download it and review it in preparation for the working session, and pull from it, the elements that you think are most relevant and helpful to you, or that you would like to explore a little bit more together during the working session. And so this is an actual physical PDF document. It's a book about 80 to 90 pages long, and I would encourage you to read it if you haven't. And you'll notice that the formal title of the ASPIRE guide, which is its shorthand name, is Designing and Delivering Whole Person Transitional Care. And you'll remember, for those of you who have seen this before, this is the driver diagram that, that we developed over 5 years of field work, looking at who are the teams that are getting success and who are the teams that are working hard but not yet getting success. And our job was to figure out what is the difference between the two, because I know you're all working hard. Some of you are getting the success you want to see, and some of you are working hard but not yet getting the success you want to see. And that is where we really dove in to develop the ASPIRE methodology. What distinguishes those two groups of hardworking teams? And really, it's in the two primary drivers. Successful teams have an excellent data-informed, root cause analysis guided design of their strategy, and it's multifaceted in nature. And successful teams deliver on a multifaceted portfolio of strategies, really focusing on reliable implementation of delivering their strategies and continuously improving. And that's really what we're going to talk about today. So design and deliver are the key success factors of a robust and successful readmission reduction strategy. And then we've gone through, you can see the check marks, we've gone through a webinar on each of these individual secondary drivers, each of which, right, we've already spent an hour on. So a lot of content that you can go back and review in the ASPIRE guide. So if part one of the ASPIRE guide is design and part two is deliver, this is now the part that you can't find. This is the post-ASPIRE guide field experience around implementing. And so one thing that I've learned is, you know, and you all know this as well, is the best laid plans, the most beautiful strategy on paper, does not in and of itself reduce a readmission. The only thing that matters is the degree to which we have successful implementation of whatever it is you've already decided is high leverage and strategic for your organization. And so, so some of the key implementation elements that really define success are here in this summary box. And I'm going to not read that box out to you, but rather you might come back to this slide as a summary slide around how the content of the ASPIRE guide gets married with the implementation insights from success in the field as we move through the rest of the content today. But what I really want you to get through today is to understand or be able to describe the elements of the ASPIRE Plus operational dashboard. This is measuring what you're implementing on a week-to-week basis, using that implementation data to drive to high reliability. And it's only when we achieve high reliability that we can get the outcomes that we wish to see. So an operational dashboard is critical, a critical component of every successful readmission reduction story. And I'd like you, as we go through this hour together, to be able to articulate 3 ways that you can better implement your pneumonia readmission reduction strategies, whatever they are. How can we deliver them more effectively and more consistently, more reliably in order to get the results that you're hoping to see? So again, this is just to remind us that we need a data-informed and root cause analysis grounded design of our readmission strategy. We need to deliver a multifaceted portfolio of strategies. You already know there's no one thing we can do to reduce pneumonia readmissions. We need to do several things, the old Swiss cheese model, as we've come to call it. And then whatever it is we decide, ultimately design and deliver our decisions, we need to have dedicated time, effort, measurement, and continuous improvement as we drive the implementation of those strategies. Whatever those strategies are, we need to deliver what you intend to deliver for the patients that you targeted. So it would be great to hear from you in the chat how many of you measure the extent to which you deliver the knockout pneumonia interventions or your readmission reduction strategies to patients with pneumonia at your hospital. So as you chat into the chat box, let's move into high reliability, which is otherwise known as effective implementation. So here's the thing about readmission reduction work. It can't work unless we do it. And so, now that obviously seems really, really simple, but a lot of times I'll meet readmission reduction teams, and they'll say, we've got a great navigator or two. We've got, our EMR has really fancy predictive analytics. We've been tracking and trending our readmissions and reviewing our results. The first question I ask is, what's the size of your target population, and what percentage of your target population actually receives the intervention or interventions that you've decided they need in order to reduce their risk of readmission? Oftentimes, teams don't know. They're tracking their data at the total target population level or even at the hospital-wide level, and they don't know what percentage of their target population is actually receiving the intervention. What they do know often is how much work effort have we put into it. So you might say we have 2 nurse navigators working full time. Well, that's work effort. That's not what is the successful delivery of service to the target population patients. So when we're talking about a clinical intervention, the intervention can't work unless it's delivered to the patient. So if we offer a post-discharge home visit and the patient declines, well, that's not a completed service. Offering and trying is not completed delivery. And that is really a key difference. It's a tough reality, but it's a really key distinguishing factor of success versus working hard and not having success in readmission work. Similarly, when we move from the level of the individual patient in bullet point number 1 to our target population, the knockout pneumonia readmission program cannot be successful in reducing pneumonia readmissions unless we deliver our readmission reduction interventions to a majority of the pneumonia patients a majority of the time. So that's why high reliability and effective implementation are absolute priorities. Once you decide who you're going to focus on and what you're going to do for them, the hard work is delivering the intervention to a majority of the people a majority of the time. Many hardworking but unsuccessful programs, many hardworking but unsuccessful programs are focused on measuring results for the patients who enrolled, consented, or received services. And that is a blind spot for some readmission reduction teams out there, because they've set themselves up, if you will, to only know their one piece of the pie. Of all the people who said yes to us, of all the people who consented or enrolled or received a visit, this is their readmission rate. We're not working at that level in readmissions. We're working at the level of the target population, right? Of all pneumonia readmissions or CMS pneumonia readmissions. The penalty, whether it's the penalty program or your star ratings or some value-based contract that you have, the only thing that matters is results at the population level, the target population level. And so if you have set yourself up to know what the results are for the patients who consent or enroll, you're only seeing a very small slice of your total target population. So what we need to do in bullet point number 4 is we need to focus equal attention in our operations on knowing who are the patients in our target population that we did not serve, as well as who are the patients in our target population that we did serve. And a lot of the problem solving needs to come around figuring out what is it about the way we are approaching our patients, engaging with our patients, offering our services, delivering our services that is causing us to have failures in delivery. And you can see how that really expands your operational management perspective when you focus as much on the patients that you're not serving as you are on who you did serve. So we'll talk a little bit more about that right now. Now, this is the busiest slide of the whole deck, so hang in there and give me a minute to walk through this. But this is really, this is at the core of why some really great programs are not seeing the results they want to see. And it all comes down to math. So let me walk you through the math here. So population A, I'll just call this your hospital's pneumonia population, okay? Population A has 100 discharges per month. Now, I said 100 patients because we talk about people and patients. But as you all know, and just ask yourself if you're doing this, when you're talking about delivering service to reduce readmissions, our actual unit of measurement is not a human being, but rather a discharge, right? Because every discharge is a potential readmission, including the humans who might be back multiple times in a month. So what you want to be sure to ask yourself right now is, when we measure at the target population level, are we measuring pneumonia discharges per month? And are we measuring service delivery based on that discharge as our key denominator? Let me know if you have any questions about that. So at your hospital, we're just going to say at your hospital, your knockout pneumonia target population has 100 discharges per month. And we know that at baseline, that your pneumonia patients have a readmission rate of 15%. And so we expect that out of 100 pneumonia discharges, here's a little bit of math, if you have a readmission rate of 15%, we expect 15 readmissions, right? 0.15 times 100 is 15. 15 readmissions out of those 100 pneumonia discharges. Our goal is to reduce readmissions by 20%. So what does success look like? If we successfully reduced these pneumonia readmissions by 20%, that's 0.2, excuse me, my typo from a different, my typo is 150. That's 0.2 of 15. 20% of 15 is 3. So our goal would be to take out 3, we would have 3 fewer readmissions out of our 100 pneumonia discharges per month. So that's our goal. That's what we're setting up the program to be. Okay, so that's the design. Now, we're going to move into operations. So our program, our knockout pneumonia readmission navigator or team, targets those 100 pneumonia discharges every month. So program A is your pneumonia readmission reduction team, and they're targeting the pneumonia patients. So on a day-to-day basis, let's just say you have, let's say that you have many people, in case management and hospital medicine and your readmission committee, you're trying your best to identify and huddle who is a pneumonia patient, who needs to be approached, and then deliver some enhanced transitional care services to them, right? Pretty typical, right? You have to identify, and you have to assess, offer, and deliver. So your knockout pneumonia readmission team is able to successfully identify only 50% of the pneumonia discharges from your hospital, and you never knew that before. But you have your coder and your data analyst run last month's numbers, and it turns out there were 100 discharges per month. You go ask your pneumonia readmission team how many people did you identify, and they only found 50. So there's a gap there we have to learn about. And then but when they do find a pneumonia patient on the floor in the huddles or through flagging in the EMR, well, they're getting to 80% of them, right? And we know that's pretty typical because sometimes you go into a patient room and they're off getting, scoped or something. And so you miss some people some of the time. So that's pretty good. When they find a pneumonia patient, they're able to approach 80% of them about the Knockout Pneumonia Transitional Care Program. However, when they have that discussion about, dear patient, we have a Knockout Pneumonia readmission program, would you like us to follow up with you? Only 50% of them say yes, and 50% of them say no. And you guys probably know that's actually a pretty rosy picture at baseline. So, so to summarize, case finding has an opportunity. Once we find a case, we're able to get to our patients to offer the service, but once we offer the service, only 50% are saying yes. This is absolutely essential information for each and every one of your readmission teams to track on a weekly basis. So, what does this mean for your Knockout Pneumonia readmission team? It means that they're working hard all day, they're huddling and they're screening and they're getting to the bedside and they're offering services, but they actually serve 20 pneumonia discharges per month because they identified 50%, which is 50. They approached 80%, which is 40, and 50% of them accepted. So that's 20. That's how the math works out. You see how that works? So actually, they only served 20 discharges that month. Now, those 20 discharges had the same readmission rate, right? They're still your pneumonia population, and we're going to assume they have the same readmission rate of 15%. So 0.15 of 20 discharges means 3 readmissions are expected among the 20 discharges that you served. And our goal is to reduce those 3 readmissions by 20%, which is 0.6, right? So it's less than 1 readmission. So we're even if we're successful, and we are. So your Knockout Pneumonia readmission team here on this 5th bullet is actually quite successful. When you serve 20 patients, you are basically able to avoid 1 readmission out of those 20 discharges because your team is really good. There's nothing wrong with your team. See, this is the key. Your team is good. When they get through this funnel of identify, approach, offer, and deliver, when they get all the way to deliver, well, what they do is darn effective. So this is what really confuses a lot of teams, because you know your teams are good when they get to your patients. But so here in this example, your team is successful in reducing readmissions for the patients they serve. That means they did reduce 0.6 or less than, or we'll call it 1 readmission that month. But here's the math, going back to the population level. What is the impact of your knockout pneumonia team on pneumonia readmissions? Well, you avoided 0.6 of a readmission out of 15 total readmissions that your pneumonia patients had that month, which is a 4% readmission reduction. You were shooting for a 20% readmission reduction. So it looks like your program is not successful. Does that mean your team is delivering an intervention that's not effective? No. Actually, your team, when they delivered services to the patients, they did a good job. And so the problem is not that the patients are too complex, because when you serve to those patients who said yes to you at the end of that funnel, right, they were not complex. You do know what works. The problem is the gap upstream in operations, the gap between your target population and the patients that you actually served. And the good news is this gap can be closed. And when you do close this gap between who's in your target population and who in your target population are you serving, then you get the results you are expecting and hoping to get. So what do we do for your knockout pneumonia readmission team? So currently, the good news is opportunities abound. All hope is not lost. In fact, when you first kind of take this management approach, it's actually quite exciting. As I hope you can hear in my voice. It's actually quite exciting and empowering, because you realize, wait a second, I am targeting the right patients, i.e. pneumonia patients. We all know that they have high readmission rates. So we are targeting the right patients. We do have a good team. And so it's about our management and our operations, and their opportunities abound to change the way we're executing our program before we throw the baby out with the bathwater, if you will. So currently, Program A is identifying 50% of the target population every month, right? And, oh, excuse me, I was talking to a larger hospital, so I didn't remove some zeros, but we'll go back to your example hospital with 100 pneumonia discharges per month. If you're only identifying 50% of the target population, then already you're behind the 8 ball, right? You cannot have success unless you can figure out a way to reliably identify your pneumonia patients while they're still with you in the hospital, and minimize the chances that we'll say a heart failure patient gets coded out as a pneumonia post-discharge in, downstairs in the coding department, right? So that's about identification and flagging and huddling, maybe some redundancies, maybe serving people who we don't know if they're going to get coded out as a heart failure or pneumonia, because quite honestly, they've got both. So you err on the side of serving them instead of not serving them. Well, you're never going to be wrong. That a patient with heart failure and pneumonia, they are doubly at risk of readmission. So you're not wrong to err on the side of including them and offering the service, because that's going to make your results better in the end. So number one is we've got to work on real-time, robust identification of your target population. We've got to move it from 50% identification to near 100% identification. So number two, we say, well, when we do have a list of pneumonia patients, we approach 80% of them. Well, as you can see, the way the math works, every decrement, every patient that we potentially lose is a lost opportunity for our program to be successful. So while 80% is pretty darn good, I would put a little effort into trying to get that to over 90% on a consistent basis. Okay, and that could be, there's a lot of problem solving there that, again, would be specific to your hospital and your interventions, but are we missing people who are discharged later in the day, or are we missing people who are approaching people who are discharged on a Sunday because, no program staff team or no weekend coverage knows about the knockout pneumonia transitional care program, or whatever the case may be. So there are some ways to say, why would we be missing, if we knew the patient had pneumonia, why would we fail to offer them the intervention? And that's going to be specific to your day-to-day operations. And then third bullet point is a fantastic opportunity, which many readmission teams would say is a frustration of their program, but it's actually proven to me to be a great opportunity to unlock innovation, which is, by the time we identify who has pneumonia and approach them to offer the transitional care service we want to offer them, if we're hitting 50% say yes and 50% say no, well, guess what that means? That means we need to change. We need to change how we approach the patient, how we engage in a helpful, trusting relationship. We need to change the words we use, the labels we're calling our program. I think I told you this in a prior webinar, but one of my teams started out by introducing themselves as the high-risk social worker from the complex care team. Well, to a doctor and a nurse, that sounds like a pretty darn smart, impressive person, right? High-risk social worker from complex care team, you and I would want to meet with that person any day of the week because he or she is just a crackerjack problem solver, right? However, if you listen to that label from the patient and family perspective, it almost sounds like we're carting them off to jail. It's scary. It's overwhelming. It's labeling. It's distancing. And so I'll talk about this a little bit more in a few slides, but if you look at our performance and say, when we offer the service to patients and 50% decline, what we need to do is understand, why are they declining? And our instincts are to say, well, patients don't want anyone in the house, or patients are non-compliant, or patient is disagreeable, or there's something wrong basically with the patient. but I encourage us, and I've had great success when teams kind of turn the mirror on themselves and say, what are we doing wrong, such that we're not approaching the patient in an effective way to get them to say yes. We can really have some breakthrough in that part of our program. And then finally, not to be ignored, but our expected impact, or our goal, is to reduce readmissions by 20%. Now, we want to reduce readmissions by 20% for the whole pneumonia population, or whatever your target population is. Guess what that means? That's all comers. That's whether you identify them, whether you serve them, whether they say yes to your program or not. So what does that mean for the effect of the impact of the service you actually deliver? The impact of the service you deliver has to reduce readmissions by more than 20% in order to achieve your population goal of 20%. So rather than being happy in the scenario that I told you, that the readmission team is doing a great job, they're reducing readmissions for patients that they serve by 20%, we now need to dust off our assumptions about, is 20% the right goal for the patients served? It is the goal for the population, but if we serve a patient, we want a 25 or 30% reduction for the patients served, if that makes sense. So each element of that, of operations, can be optimized. We can change what we do and how we do it, which brings us to, the very heart of continuous process improvement. This is how Toyota became excellent, right? This is how we manage and optimize components of our process in order to get better performance of the whole system. And so this is, again, something that keeps readmission work very fresh and relevant to me, because my priority is outcomes and system optimization. And so this is really where, we've spent so much time talking about pneumonia and epidemiology and root causes and interventions. All of that comes to only can come to life if we actually implement, manage, and optimize our program that we've decided to deliver. So reliable implementation requires us to measure what we do and who we do it for. And then using the principles of system continuous improvement and system redesign, we need to look at our performance and not explain it away, which sometimes is natural. As I said, patients decline because ... because of them, and we need to use our performance data and look in the mirror and ask ourselves always, how can we deliver the service better? What can we change? What can we do? And what I like about that is it empowers us to get out of the zone where we blame patients for not accepting services, and we keep the focus on what can we change, which is empowering, instead of disempowering. When we feel like sometimes, as we do, if you will, blame patients for not accepting our services or adhering to our recommendations, that's disempowering, right? We all looked at each other and said, well, what more can we do? We can't do anything. If they don't want to be helped, we can't do anything. And that puts us in a disempowered position. But when we use our own management operations data to say the goal is high, consistent reliability of successful delivery of the services that we have already decided our patients need, then we empower ourselves by saying, what else do we need to change about how we're doing our work? So here at the bottom of the slide is a very simple but tried and true. If you start with nothing else, this is what to do. It's the simplest 3-part dashboard you'll ever see. I totally believe in simple measurement, because at our stage of the game in readmission reduction work and population health work, we are so far from needing granular data. The simple data still does the job, which is really good news for us. So this is something that you can do on a unit level. This is something you can do for your knockout pneumonia target population. But this is something I really encourage you to just use this 3-part dashboard. And I like week to week, month to month, and having operational PDSA meetings about this information. So in this simple example, you would have seen that you had 100 pneumonia discharges this month. You would have seen that you only saw 20 of them, right? Because you missed 50%, and then 80% you approached, and 50% you were able to effectively engage. So 20 is the number out of 100 that you actually served while in-house. And we'll say served, and I put served in quotes because, again, that's for you to decide. Served in this scenario that I'm outlining for you means, well, thank you, Mrs. Smith, for agreeing to participate in our knockout pneumonia program. What I'd like to do first is talk to you about your goals of care, review your medications, review your symptoms, and set up an appointment for a post-discharge home visit. So that's if that's what you're doing, and make an appointment before you leave. So you're doing some of that, maybe not all of it, but you're doing some of that for your pneumonia patients, I'm sure. So you call that, or some version of that, served while in-house. So it's what you did for Mrs. Smith once you got to the point at which Mrs. Smith said, yes, okay, that sounds fine if you want to help me once I leave. And then you want to measure what number of target population discharges from the 20 that you served in-house, how many did you successfully serve once they left? So in this situation, served, again, is in quotes because it's going to be specific to your program. But let's say served was review goals of care, do a pre-discharge med rec, schedule a follow-up home visit, and schedule a follow-up physician visit. Okay. So in this situation, the two things that you wanted to do post-discharge, or actually I'll just simplify it. The one thing you wanted to actually do post-discharge was the home visit. So you need to measure, of the 20 people that we served in-house before they left, how many home visits did we actually accomplish? Not how many did we schedule, not how many did we try to do, but how many did we get done? The get done part is the really important one. And so in this case, the answer is 5. Now you can see 100, 20, and 5. So that gives you, instead of explaining that away, our patients are so sick, they live so far away, they're impoverished, they live in bad neighborhoods, they don't trust the medical system, and they don't allow us to help them, or whatever other, things. And I say this because, as you'll remember, I'm a practicing physician myself. I get it. But instead of saying those things and explaining away why we only served 20 out of 100 people and we only got 5 out of 100 home visits done, we use it to say, so how are we going to get better next month? How are we going to go from 20 to 25 and from 5 until 10? You keep it to bite-sized chunks, making meaningful improvement month to month in your operations. And over 5-6 months, doesn't happen overnight, but over 5-6 months, you'll find that where you started, we'll say in September, with 20 out of 100 patients being served pre-discharge, you could very well get to 60 within a couple months. You could very well go from 5 home visits accomplished to 25. And that is what will make your readmission rates go down. The served in-house and served post-discharge is the only thing that matters when it comes to reducing a readmission. All the huddling and the case conferencing, and quite honestly, the data reviews and the predictive analytics, that stuff doesn't in and of itself reduce a readmission. The only thing that reduces a readmission is doing something different for our target population patients. So here's just an example of how you can use, again, in a very empowering, proactive way. You use your data your implementation data that we described on the prior slide, and you enumerate the elements of your process. So as I said, we need to identify people, we need to get to the bedside to offer them services, we need to serve them in-house, and we need to serve them post-discharge. And then you and your team can say, well, where are we with those elements of our knockout pneumonia process in terms of reliability, and keep it simple: low, medium, or high. And you can see there's use of just a very qualitative description. The specifics here don't matter. It's, you know what, our reliability of doing home visits is pretty low. Got to be honest. We've done it 5 times out of 100, so we have to call that low right now. You know, our ability to get to the bedside and offer the service is pretty high, but high medium, because what you want to do is keep your definition of high, basically meaning it's consistent and hardwired. So the journey to high is the highest bar. It means it's done all the time with very rare failures. So most of the work is going to be low to medium, and then you have your team meetings with your readmission team, your unit champions, your readmission committee members, and you talk about what do we need to do to go from low to medium or medium to high? And that is a very productive, specific conversation that will advance your prospects of getting better results on a month-to-month basis. So that is the experience, so let me bring you to three specific readmission implementation measures that we have found have been pretty consistently helpful for high risk of readmission target populations, including pneumonia, including discharge to home or to post-acute care, including patients with palliative care needs, including patients with poverty, including patients who are or who are high utilizers of the inpatient setting. So for high risk populations that include your pneumonia patients, but also include others, these are some of the these are 3 key I'll call them management elements on your dashboard that if you can optimize each of these 3 in terms of the delivery of your services, you will see better outcomes. So I'm going to talk. So here's the dashboard, and I'll just pause to say these are real data from real community hospitals that I've worked with. I mean, it's just incredible to see the concept in action and how well it works. And that's why I'm sharing it with you. So I'm going to talk about these 3 things, and then we'll wrap up the webinar for today. So close the gap. I've really emphasized that today, and I have a slide on that. So how do you close the gap between the patients in your target population and the patients that you're serving? Number 2, drive up completion rates. As I say here, attempts don't count in readmissions. So making 3 phone calls per patient doesn't count. The only thing that counts is a completed phone call, if that's what you're doing. A completed service is the only thing that can reduce a readmission. And then number 3 is something that you may not have thought about, but it's been very successful, especially for small readmission teams or large readmission teams. Everybody always tells me they don't have enough resource. And so this 3rd domain is addressing what I hear from small and large teams alike, which is we don't have enough. And so what can we do? Instead of saying we can't get another FTE, what we need to do is say, what's the purpose of our team? The purpose of our team is to reduce readmissions. How do we reduce readmissions? It's by serving patients. So how can we use our time better in the service of patients? And let's look at how we spend our time individually and as a team and drive up the number of patient-facing contacts with our exact same team. And again, this is from an actual team that used this concept and doubled the amount of patient-facing work they were doing because they reorganized their own internal workflows. Really cool stuff. So one slide on each of these in detail. So I've talked about the importance of closing the gap between the target population and the served population. Again, this is from a real hospital. They were targeting a broad high-risk group, and there were 350 plus or minus discharges per month in their target population group. And you can see that they worked really hard on getting to a point where they were trying to close the gap, and then they plateaued for a number of months. I mean, look at the number of months there. They plateaued for about 5 months. They were getting really frustrated, and they thought, like, there's just no way. And they wanted to cut their target population because they said, there's just no way we can figure out how to reach these people that we're still missing. And this is what the pivot needed to be for them. So in the first phase, they worked on reliably and identifying their target population. So that meant working with IT to get automated flags and lists so that the team wasn't spending time in rounds or chart review and doing manual work, that they could be pushed a list of patients that met their target population criteria and get right to the bedside. And this was the team who had the, what I call her, the high-risk social worker from the complex care team. And so in this plateau, we re-scripted. We said, well, why do you think only 30%, only 30% of the patients were saying yes to the service? Why do you think only 30% of the patients were saying yes to the service? Because they were calling it the complex high-risk care team, intensive care team. It was complex, high-risk, intensive. And gee, again, to a doctor or to an administrator, that sounds like a really excellent clinical model, or a really good use of my money, right? Is intensive and high risk and clinical. But to a patient, it is absolutely terrifying. And I don't want to be a part of that. I don't want to be called anything like that. So they actually worked very hard on scripting, engagement, and they took an opt-out approach. They started to say this is a continuation of your care, and they avoided any labels that made it sound like the patient was being put into a special high-risk, intensive, complex program. This is lessons from the hard-won lessons that I really encourage you to consider. So basically, they stripped away all formality. And they have a script which roughly goes like this. Hi, I'm Amy. I am a, fill in the blank, I'm a social worker. And part of my job here at St. Mary's Hospital is to make sure that you have everything you need when you leave so that you can recover back to good health. And so part of my job is to schedule a time to come visit you in the next few days. Would Wednesday at 2 o'clock be okay? Right? Boom. All the way to what we need to do, which is deliver that service. And so that is what you can see at the end of their run chart here, that the re-scripting and the different engagement techniques and the opt-out approach instead of the opt-in approach allowed them to close the gap. And do you know when their run chart went down? After November. They worked for all of those months, serving all of those people in the light blue line, no readmission results. As soon as they narrowed the gap between the target population and the served population, that's when they saw the readmission rates come down. Next is this is a completed contact. So whatever it is that you think you want to do, phone calls, home visits, community visits, navigation to social service agencies, behavioral health follow-up, whatever completed contact it is, we have to move away from what we tried to do to what we actually completed, and allow that data to inform us on how we have to continuously improve our service delivery in order to complete what the patients need, not just try to get done what the patients need. So in this case, and this was a $70 million program up here in Massachusetts that we ran. The requirement for the program was a 48-hour completed contact. And as we started in Q1, most everybody was making phone calls, right? And this is pretty typical. You turn on a post-discharge call program, and you're pretty much going to hit 35% completed calls just because you woke up and went to work that day. So So 35% was completed calls, and we worked a little bit harder, and we, used some rescripting to make sure that we were, like calling cell phone numbers before the patient left and getting, doing redundant work at the bedside. And we got a little bump there, but we could see clear as day we were not going to get past the 50% mark. So what we needed to do, because of that, instead of saying, oh, patients have cell phones, they run out of minutes, and they, all these kind of things, they screen their calls, they think it's the financial officer calling from the hospital or whatever. We said, what do we need to do? Because we have a job to get done. And in this program, there was a payment incentive for hitting 80%, right? So it was mission critical, dollars on the line. And so what we did was we said, look, the objective here, what's the objective that's going to reduce the readmission? It's being in touch with the patient and any sort of contact. And so we broadened our thinking to say any contact is good contact. So texting, home visit, home health visit, a social work visit, an office nursing visit, a nurse from the PCMH being in touch with the patient. Then the need from the patient perspective was somebody got in touch with them within 2 days and reviewed the plan, asked them about symptoms, and encouraged them to follow up with their appointments. And so we broadened what does completed contact look like, because it's not about us making a phone call, it's about the patient receiving the information they needed. And that was very helpful paradigm shift. The other thing that I would be remiss if I didn't mention is we got a breakthrough because we started texting. And I'll just tell you, I personally made 2 appointments in the past 2 weeks. I've had 3 text reminders. Like, to think that we can't be texting patients, it's just not consistent with 2018. So we don't have to text people their, psychiatric diagnoses or their HIV viral load. We're texting people a reminder of your appointment, or this is the hospital calling, texting to review your care plan. Can you call us back? Your discharge plan or your follow-up plan. So we did outbound texting with the invitation to either text us back if you have no questions or call us back if you want to review your plans. Again, really worked for a segment of our patients, especially the younger or the middle-aged adults between 30 and 70, right? So that was a really helpful breakthrough. And then finally, I just to allude to this, basically it was a workflow optimization. What you see here is how many patient-facing contacts, and that was something that the team defined for themselves. How many service contacts were we doing on behalf of our patients with the same amount of FTE work, right? Like, let's say this team was 2 nurses, a social worker, and a non-clinical navigator. Well, at the beginning, they were a brand new team. And so they had never worked before, they had never together before, they had never worked with in this environment before, they had never worked on these high-risk patients in this program before. So what they were doing, and this makes total sense, and again, it's not a mistake, it just is what it is, they were huddling in the morning, they were huddling at noon, and they were huddling before they left, and they were huddling so much that they were using up each other's, 5 FTEs worth of huddle time every time they met for 30 minutes. And they didn't think that they were huddling too much, but when they saw, well, we're only getting, this much patient-facing work done because the rest of the time we're huddling, they streamlined their huddle process, they streamlined their travel schedule. This was a team that was doing community work, so they batched their visits, by community or by nursing home. And they were able, you can see, to get so much more patient-facing work done with the same amount of workforce that this, again, is a great area of opportunity for your readmission team to look at. And so, again, real data from Aspire Plus implementation teams. These are the 3, working with that Aspire Plus implementation model, the operational dashboard, and optimizing the 3 domains that I just went through, team after team after team after team, getting the results that they want to get for the highest risk target populations that many of you are targeting, including pneumonia patients. That run chart number 2, by the way, is heart failure, pneumonia, and COPD and dementia. So their target population was anyone in the hospital with heart failure, COPD, heart failure, COPD, pneumonia, or dementia. And they reduced readmissions in that target population by 50%. 2 persons on the job. Small hospital, a nurse and a social worker with that high-risk target population using these methods. So this can sometimes be best done in small environments, but by all means, these strategies are really getting results. So as we move into the October prep session, we've shared with you so much about design, delivery, and implementation. I'd encourage you to look over these recommendations and ask yourself, are we set up to really manage the implementation of our knockout pneumonia interventions in this way? And come with questions. Come with questions to the October session. We want to set you up for success. That's why you're attending these webinars. That's why we're coming in November. And so this would be right for you to review maybe the Aspire guide and the various recommendations from our 6-part webinar series, and ask yourself which, of all this body of work that has been shared, which ones are you really ready to jump into? Okay, as we wrap up, and I know some of you have to go, I have one new program announcement for some of you that might be relevant. For anyone who is affiliated with the American Hospital Association HREP HIN or the Vizient HIN, I'm happy to announce that we will be launching a 6-month intensive program to disseminate the very successful, what I call the MVP method. The MVP method is specifically for multi-visit patients, formerly known as high utilizers, and it's been used successfully now by 100 teams up here in the Northeast, and we're ready to disseminate it nationally through the AHA and the Vizient HINs. And so if your hospital is part of those networks, reach out to me. We have an informational webinar tomorrow as well as next week for the various HINs. And we're really trying to get the word out because it's a fast-moving train as the new season for HIN work starts October 1st. So thanks for letting me announce that. And thank you for coming. We'll look forward to seeing you back in a month. And by all means, come with questions, email questions in advance. You've got Karen and Trish and myself. So please let us know how we can help you as we come into our final month together here in the Knockout Pneumonia Readmissions campaign. Thanks a lot. Have a great day.
Thank you, Dr. Boutwell. This is Trish Vandersee. So just a reminder, on October 4th will be our next webinar. Information will be going out soon about registration for that. The recording as well as slides from today's session will go out within 24 hours. You should receive an email for that. And as Dr. Boutwell, one of her slides mentioned, the November 2nd workshop that we are actively recruiting for registration right now. So registration is open, and if you have any problems or any questions as you and your team are preparing for that session, please don't hesitate to reach out and contact me or Karen or Dr. Boutwell herself. All right, this concludes today's session. Have a great day.